Hi, everybody, and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Deborah Foreman, the Educational Programs Coordinator here at MS Focus, and I'm joined today by Dr. Ben Thrower, who's going to be presenting a 60-minute town hall Q&A. Now, I'm delighted to introduce you to him if you've never met him before. Dr. Thrower is the medical director of the Andrew C. Carlos MS Institute at the Shepherd Center in Atlanta, Georgia. And he's also the senior medical advisor for the Multiple Sclerosis Foundation. Thanks for being with us today, Dr. Thrower, and we can get started as soon as I give everybody some directions in case they're new here as to how to do the Q&A. So if you have a question or comment, you can ask it using the Q&A button in the app. And that also allows you to send your question anonymously if you choose to. Please do not, I repeat, do not type your questions into the chat area, as we're going to leave that alone and we're going to go strictly to the Q&A area for your questions. If you can also ask your question, or if you want, you can ask it live by raising your hand and I'll press the button to ask you to unmute. If you're on a phone and you want to ask a question, just do *9 and you can do it that way. Let's see. Either way, you'd have to unmute. And I think that brings us to that. Dr. Thrower, is there anything you want to say before we start with questions?
I think we are ready to roll.
Okay, let's see. We have a few already. Debbie, I like that name, Debbie. Do you think it would be would you think it would be difficult to get Tolebrutinib? Oh, I'm so bad at these names. Oh, it's embarrassing. Tolebrutinib
You did well.
when it is approved for use for progressive MS.
So Tolebrutinib should get FDA approval in late September. When a drug gets FDA approval, that doesn't mean that it's immediately available. Unfortunately, we all have to deal with insurance companies, and that I think one of the questions is how quickly do insurance companies put it on their formulary? I think the other question is, does the drug company that's manufacturing Tolebrutinib, do they step up and have some kind of program to allow access while we're waiting for all the insurance companies to get their acting gear? So I wish I had a really definitive answer. I mean, I'm as curious as Debbie is to know what that process is going to look like. We're also waiting to see what the safety monitoring requirements are going to be. Well, we do expect that there's going to be some degree of blood testing to monitor liver functions. We just don't know how frequently that's going to be. So, hopefully everything goes smoothly. It will be really the first drug FDA approved for secondary progressive MS without activity. So we're excited about that.
Thank you. Keith said, do you have any thoughts on seizures? Because he had his first one a few weeks ago. He took a nap and woke up in an ambulance. That had to be
So
scary.
Yeah. So seizures are more common in people living with multiple sclerosis. Seizures result from a lowering of the human seizure threshold. So you can make any human have a seizure if you irritate our brain enough. And MS lesions can serve as kind of an irritating focus, if you will. That said, the majority of people with MS will never have a seizure, but it is more common. So if you've had a seizure and there's no better explanation than the MS, then the question is going to become, do you need to go on a medication for a while? And if you do, there's always that hope that it's not a forever thing, that at some point we can stop that medication if it's felt like the seizure risk has lowered.
Okay. And it can't be from medication side effects from
Typically,
Dilfaprodine?
so there aren't many medications with MS that we use that would cause seizures. So some that we do worry about would be dalfampridine or PIRA, 4-aminopyridine does lower the seizure threshold. Some of our antidepressants, like bupropion, can lower your seizure threshold a little bit. Withdrawal, if you were on baclofen and you stop baclofen abruptly, there can be some seizure risk. So there are some medications where we would want to take a look at that and see if that's playing a role.
Okay. And Debbie has another question. She said she recently had her 1-year follow-up MRI. One of the findings was the following: there is mild distension of the optic nerve sheath, more conspicuous on the current exam and correlate with fundoscopic exam. How concerned should she be? Um, do I need to see my optometrist?
So, with the optic nerve sheath is a little bit dilated. It could be sort of just a benign normal variant. But so when they say fundoscopy, that's when we take the little ophthalmoscope, the light, and look in your eye. So we're looking at your optic nerve to see if there's any swelling there. I do think it's worth getting in with your eye doc. We love our optometrists, but I do feel like in people with MS or any other health condition that could affect the eyes, I do think seeing an ophthalmologist is probably a good idea. Optometrists are great, for our lenses and corrective issues, but where you're living with MS, I do think seeing a good ophthalmologist would be the probably a little better idea.
Thank you. Can you give Carol your thoughts on MS and parasites?
Yeah, so this has been kind of a weird thing that's popped up on social media here recently, and I'm not sure why now. The study in question was done by a pathologist in Florida back in 2021. Why now it's getting attention, I'm not sure. Um, I think it is absolutely wrong. And so what the pathologist was claiming is that MS is due to parasites, and this was based upon some findings on brain examination, spinal fluid examination. The problem is it was a very small sample. I believe there were 10 individuals that they looked at, and it flies absolutely in the face of every other bit of science that's been out there for much, much longer. I would argue that the overwhelming weight of the evidence argues that MS is not due to parasites, but that in fact parasites are actually associated with a lower risk of autoimmune conditions. And there's so much science out there that argues for this. The way the human immune system deals with parasites is actually kind of the opposite of what's going on in multiple sclerosis. So I would not run out and start, doing parasite cleanses and things like that. Now, there's an interesting, I think, little side note to that. Ivermectin has been kind of a hot topic, going back to the COVID pandemic, when people were looking at ivermectin as a potential COVID treatment. Ivermectin's been around forever as a parasite treatment. Um, is it possible that ivermectin could have some positive effects in MS? It's possible. A lot of drugs that were designed to treat one thing could have positive effects for for completely different reasons. If ivermectin is ever shown to be anti-inflammatory in a way that could be good for MS, and that's a big if. We don't know that yet. It's not because it's killing parasites. It's because it's doing something else in the immune system.
Thank you. I don't know if it's Margie or Marge, but she said she's heard a little bit about using a low dose nicotine patch to relieve some MS symptoms. Is this real science? And if so, can you expound on it?
I think right now it's more at the anecdotal and small study level. I don't think we have enough data yet to say that it's an absolute. Um, I think it's probably a relatively low risk thing to try out. There's some thought that it might help with energy levels or maybe pain management. I don't think there's any good evidence to say that low dose nicotine is actually a true disease modifying therapy. So probably I would wait till there's a little bit more science and some larger studies before I would go down that path. But yeah, again, if someone really, really wanted to try it right now, I don't think there's a lot of harm to it.
Okay, thank you. There are two questions that were put into the chat area. I've asked for them not to be there, but I don't want to ignore them. So I'm going to read those, but we will not take any more after that. Okay. Deborah says if you are JC positive and stop Ocrevus, is there a greater chance of getting PMI or PML? Forgive me.
So Ocrevus and the other B cell therapies, they're the package inserts and product information packets will mention some risk of PML. The overwhelming number of cases, and they're small, but the cases that we've seen of PML with B cell therapies are typically what we call carryover cases. The person was on a drug where there's a known risk of PML, like a natalizumab or Tysabri. The person stops that drug, They then go on something like Ocrevus. If you stop natalizumab or Tysabri due to a high JC virus antibody index, your PML risk doesn't go back to zero or close to it for about 6 months. So in that 6 month window, if you were to start Ocrevus and you develop PML, it really wasn't the Ocrevus that caused the PML. It was the preceding Tysabri. So I don't worry very much about PML risk with our B cell therapies. To my knowledge, there has maybe only been one or two true cases of PML directly as a result of the B cell therapy like Ocrevus. And the one I know of that was well documented was in an older gentleman that started Ocrevus. And before he started the drug, he had a very low lymphocyte count. So there was something else going on with this gentleman's immune system that put him at risk for being immunocompromised. And you could argue probably should not have been put on Ocrevus in the first place. Oops, you're muted, Debbie.
Thank you. That helps. My brain MRI states total volume went from 8th percentile to 2nd percentile from 2004 to 2025. I don't have cognitive issues. What can I do to slow this loss?
So that may just be normal human aging. So, as we get older, unfortunately, all of our brains shrink a little bit, MS or not. And so, over that time period, if you graph that out, that may not be so much MS as it is just normal human aging. As much as, we like to see people stay physically active, I think staying cognitively active is one way of potentially protecting our brains and maintaining cognition. So just challenging yourself cognitively, whether it's reading, taking on new cognitive projects, doing crossword puzzles, just something to keep your brain active and challenged.
Okay, and Lisa is asking, do I have an MS flare or functional neurological D/O? I have bouts of slurred speech with halting cadence. My left eye closes and the left side of my face droops, sometimes accompanied by left side weakness. My neurologist said I should get therapy as my symptoms are related to trauma. I have had these symptoms since 2009. My parents died 2016-17. My best friend died in 2023, no prior to trauma.
So when neurological symptoms are kind of, worsening transiently in a person with MS, I think her question is a good one. Is it a true relapse? Is it a pseudo exacerbation, or is it kind of, normal baseline fluctuation? So the definition of a true relapse would be new or worsening neurological symptoms that persist for at least 24 hours, and we don't have a better explanation. If there's something driving those symptoms, a urinary tract infection, any kind of infection, heat exposure, sleep deprivation, stressors, then we kind of put that into the pseudo or false exacerbation category. And then the thing that is really tricky with MS is people have good days and bad days, and it's their symptoms fluctuate, some for no good reason. And so I think, trying to sort those things out. If the symptoms are that she's describing are less than 24 hours in nature, it's more likely that they're in that either pseudo exacerbation or symptom fluctuation camp. And then the other thing we have to throw in is it possible that someone is having neurological symptoms completely unrelated to their MS? A lot of people with MS deal with migraine headaches. Migraines are pretty common, and with some migraines there are neurological accompaniments. There can be slurred speech, visual changes, even sensory alterations and motor weakness on one side of the body as part of a migraine phenomenon. So those are some of the things that we would kind of look at to help make that determination.
Thank you. So, someone said that they started Mavenclad. They just started it, just finished year one, month one, week one today. I like that. I like saying that. Thank you. I
Yeah.
was wondering if a brain MRI should be done before starting year two, just to make sure no new lesions appear between now and then. Or is it common for lesions to occur between year one and two?
So, the immune effect of Mavenclad in terms of the B cells and T cells dropping happens fairly quickly. So you would expect that right now those cells are probably low, and then they're going to come back, and they probably are back to something close to baseline at about 6 months after that dose of Mavenclad. Um, we do like to get updated MRIs after people have changed therapy. I think the question of when is a little bit open for discussion. If the person is clinically stable after starting something like Mavenclad, you could say, maybe 6 months, 8 months after that first round, before starting the second round. I think the other part of that question is from just the practical, standpoint. Let's say that there was a new little something, would you change the course, or do you go ahead and proceed with the second course? I would argue you're probably going to go ahead and get the second course, even if there was a new little something. Hopefully there's not. I mean, Mavenclad is up there with amongst the more effective medications. So yeah, I think getting an MRI prior to the second course is certainly reasonable. Is it mandatory? Maybe not. Sometimes when we do MRIs in these kind of gray situations, I think the person living with MS has a lot of say in the discussion. Does the person just want to know where they're at? Would they sleep better at night knowing they have a stable MRI? I think those are perfectly valid reasons for getting updated MRIs.
Hmm, good information. Deborah's asking because she stopped Ocrevus about 2 years ago because after her last one, she had trouble walking and she's 65 and stable. What are your thoughts on discontinuing a DMT or going on a different one? Have you heard of others losing mobility from Ocrevus or while they're on it?
So the next month's topic that we're going to do is on this very subject, the idea of de-escalating or discontinuing MS therapies, and what does the human immune system do as we get older. There is growing evidence that the risks of a drug like Ocrevus do go up as we get older, maybe more so in women than men, and the benefits appear to be declining as we get older. There are studies arguing that the benefits of disease modifying therapies, including Ocrevus, really may go away after age 55 or 60 or so, and that we need to be having more discussions with people about the pros and cons of staying on therapies. Um, Worsening after a dose of Ocrevus, I have seen it. I don't know that I can explain it. Why would a person, would their MS act up when we're depleting their B cells? Is it also possible that it was unrelated to the Ocrevus? MS is unpredictable, and could there have been something else going on? Could it have been that with the B cell depletion that we saw with Ocrevus, maybe we put the person at a little more risk for an infection, like a viral infection or a UTI, and that's what made the person's neurological functioning get worse. At the end of the day, I think anytime a person worsens after a disease modifying therapy, and especially with age, I think having that discussion about stopping therapy is a very reasonable one.
Thank you. Heather would like to know, how does perimenopause and menopause affect MS progression?
Yeah, so there has been some research in the past, and I think there was a study within the past year suggesting that menopause could be associated with some slight progression of MS in women living with multiple sclerosis. It's I find that challenging because we do see this concept of PIRA, progression independent of relapse activity, in a lot of folks who are older living with MS. So how do you separate that out from the effects of menopause in a woman with MS? I don't know that that's an exact science. It does raise the question of should peri and postmenopausal women have discussions with their gynecologists about going on hormone replacement therapy. I think it's certainly something that we should consider. Right now, I still am probably of a mind that if a woman is not significantly symptomatic with peri or postmenopause, a lot of hot flashes or other symptoms, I probably wouldn't push hard for the person to go on hormone replacement therapy. But clearly, if there's if the person is peri or postmenopausal, seeing neurological decline and having a lot of hot flashes and other uncomfortable symptoms, probably something that we should have the gynecologist help us with.
Mm. Catherine said, can you please speak to histamine with respect to MS, exercise, and diet? She has issues with high histamine foods, and she's wondering if it's due to MS. And when she overexerts with exercise, she has the high histamine symptoms similar to HI food reactions. And thank you.
So I don't think histamine sensitivity in the diet is more common in the MS population. I think a lot of times we have to listen to our body and say, are there foods that we could be sensitive to, maybe even not even outright allergies, but just sensitivities. And not that it's an MS specific thing, but if your body is telling you that you don't do well with high histamine foods, listen to it and certainly try to avoid those things. We clearly have seen in diet research that there's no one size fits all from a diet standpoint. I think in general, we do recommend that people kind of pursue healthy anti-inflammatory diets. Things that look like a Mediterranean diet do seem to downregulate inflammation, which is a good thing in MS. If someone's not sure, whether they have food sensitivities, doing some type of elimination diet to see, what is your body telling you is not crazy. Um, One of the ways that you could look at that is with something like the Whole 30 diet plan. So, and you can look that up online. Whole 30 is just calls for 30 days, eliminating a lot of bad stuff from our diet, doing that for 30 days, see how you feel. And then at the end of the 30 days, what is it that you're really craving? Are you craving, more carbohydrates? Try putting that one thing back in. Are you craving a glass of wine? Put that one thing back in and see how you feel. And then just slowly add stuff back on to see, what your body's tolerating. My wife and I have done that years ago, and then I'll tell you, she had no clue that she had a peanut sensitivity. It wasn't an allergy; it was just more of an intolerance. And her afternoon snack for years and years and years had been some type of granola thing, and she couldn't figure out why she was feeling kind of crummy in the afternoons. And once she did the Whole 30, she found, wow, she really doesn't tolerate peanuts very well. So you can do a little detective work that way.
Wow. Did she ever, did it get worse or is she still staying away from
Oh, she
peanuts?
can't tell you if she has any peanuts at all right now. She gets abdominal cramping and just feels really,
Wow.
really poorly.
So it stays.
Yep,
Stays.
it didn't go away. Yeah.
Wow. So Fred's asking if you typically order labs and or scans after year one of Mavenclad, and if so, how soon after the second month dose?
Yeah, so there are protocols you can look up for the lab testing with Mavenclad. So what you're following are the cell counts. So we expect your B and T cells to drop after Mavenclad. And again, they're going to drop about a month after each dose, and then they should return to baseline about 6 months later. You for sure want to do labs before you give that second dose because you want to make sure that the cell counts have actually recovered. There are situations where we actually might delay that second dose if the B and T cell subsets have not fully recovered. I think we talked a little bit earlier about the timing of MRIs. That's there's a lot of individual variability with the MRI question because let's say the person before Mavenclad had active lesions on their MRI. Well, that person you're probably going to want to get an updated MRI 6 months after that first dose for sure to show that those active lesions have gone. If there were no active lesions on MRI pre-Mavenclad, I think that's where it gets a little grayer. What point do you repeat the MRI? There's probably not the same sense of urgency in repeating an MRI in a person who didn't have active lesions before they started it.
Thank you. This person was diagnosed with relapse remitting in December of 22, but the symptoms have progressed since then. They say they don't believe they've ever been in remission. How can they know if they have secondary progressive MS or PIRA?
Yeah.
Um, Currently on famidine, baclofen, and Ocrevus every 6 months.
So I think that is one of the biggest challenges that we see in the MS world is what is the appropriate label. I think that the term remitting MS or remission is probably quite misleading for a lot of folks because remission seems to imply that I have no symptoms. Uh, when in reality, what remission really means in MS is that I'm just stable. So maybe with a prior relapse, I developed weakness or numbness or visual loss, there's a chance that that symptom is not going to go away, even though you're in remission. So with each MS relapse that you have, there's about a 30% chance that you keep some symptoms from that prior relapse. And technically, you can still be in remission, even though those symptoms didn't fully resolve. So then we add the sort of the factor that those terms that we use, relapsing, remitting, and progressive forms of MS, were designed to describe the natural history of MS. Well, most people with MS who are on a disease modifying therapy like Ocrevus, we're not seeing the natural history of your MS. We're seeing a modified version due to your disease modifying therapy. So could it be that a drug like Ocrevus is doing a good job of stopping the big inflammation, but it's not stopping the smoldering low-level inflammation? And so what you're left with is something like PIRA, progression independent of relapse activity. That doesn't necessarily mean that you have a secondary progressive MS without relapses. It just may mean that you have a mostly treated form of MS where we're stopping the big inflammation, but not the little inflammation. Um, there is evidence that even our really highly effective therapies like Ocrevus may not be stopping that low level of very, very low level of inflammation. So how do we know where somebody's at? Some of the newer MRI technologies like quantitative volumetric MRI, where we can look for slowly enlarging lesions, which would seem to be one of the indicators of smoldering inflammation, would be one way that we can know kind of what's going on under the surface. Some of the newer blood testing, like the Octave biomarker panel. So this is a blood test that looks at 18 different biomarkers and puts those numbers together to give you an MS disease activity score. I think that's another way that we can help gauge where someone is at with their MS and what is the appropriate label to use for that individual.
Thank you. Trisha is 56 years old. She was diagnosed in 1991, was on beta seron from 93 until 2024, stopped in August of 24 during menopause. Um, I guess, okay, no, I guess she would have been a period. She stopped in August of 24. During menopause, that's when she really felt like she had MS. Last week, she started Zepbound because her A1C was high. If she goes back on MS meds, do you have a suggestion which med would be best if she had side effects with beta seron? She does have foot drop now and no change in the MRI. She personally feels like menopause really affects her MS.
Yeah. So beta seron was obviously our first FDA approved therapy back in 1993, and we still have people who are on beta seron. I would argue that things like natalizumab are the B cell therapies, Mavenclad, are much more effective than those older platform therapies. So if she is seeing some progression, I think the questions become should she start one of these more effective therapies? If it's felt that she might have secondary progressive MS without activity, does she wait for Tolebrutinib and see if that's going to be the best fit for her? While her healthcare team and she are having that discussion about which disease modifying therapy is going to be the most effective, I would strongly encourage her to get in with a good physical therapy team. If she's dealing with foot drop, sometimes just treating that foot drop is going to make a huge difference in just her daily life. And there's so many options now out there for managing foot drop. So I would put physical therapy with a knowledgeable therapist high on the list, right up there with getting on the disease modifying therapy.
Great. Tiffany says that she had her first sub-Q Ocrevus treatment and she's in a clinical trial. Thank you very much, Tiffany. Do you feel Ocrevus or other DMTs can cause dental issues?
So I'm not sure that the Ocrevus itself that I've seen a lot of dental issues. With a lot of our B cell therapies, we are pre-medicating with some form of steroids, and I do think we have seen more dental issues with steroids. Um, some of our symptomatic medications, like the drugs we use for bladder symptoms that are what we call anticholinergics, can be associated with really significant dry mouth. Dry mouth is a big issue for dental health. And so it may not be the Ocrevus directly. It may be the steroids that we give as part of the pre-medication regimen, and I would certainly look at our other medications and make sure there's nothing that's causing a lot of dry mouth that's going to be a dental problem.
Great. This person says that their son is 33 and has had MS for 4 years, and they wanted to know if stem cell would help.
So again, when we talk about stem cells, we always want to kind of take one step back and say, what stem cells are we talking about? Are we talking about the hematopoietic stem cell transplant, or basically a bone marrow transplant? With that procedure, we're taking immature cells from the person's blood, cells that are part of the immune system. They're immature cells that can become any part of the immune system, saving those cells, treating the person with some type of chemotherapeutic regimen that's going to wipe out the existing immune system, give the person those cells, their stem cells back by blood transfusion, and let them regenerate a fresh immune system. So that procedure is not FDA approved yet in the United States. I do think it will be at some point. There are people going out of the United States to have that procedure. It is a legitimately effective procedure. You could argue it's maybe the most effective thing we do for relapsing forms of MS. We also know that because of the risk of the chemotherapy and the period of time where your immune system is absent for essentially a month, we want to be very thoughtful about who gets that procedure. Ideally, we think that the perfect candidate would be under the age of 50 and has pretty active disease and lots of new lesions on MRI, relapses, and has probably failed one or two of our more standard therapies. The other type of stem cells would be the mesenchymal stem cells, and these are more in the neural repair camp. And so these are not FDA approved yet. Lots of interesting research out there on mesenchymal stem cells, a lot of hope that these are going to play a role in reversing disability and multiple sclerosis. So I would say these are in the stay tuned. If the research is looking promising, and also not only stay tuned but buyer beware. So just be aware that there are lots of for-profit clinics out there, mainly overseas but some in the US, that make a lot of claims about mesenchymal stem cells, saying you come here, give us 15 $20,000, we'll infuse you with stem cells, and we're going to make your MS, Parkinson's, Alzheimer's, autism, you name it, better. Just be do a lot of homework with those for-profit clinics, because there are a lot of claims being made that are not backed up with science.
Good point. Jessica and Eliza, you put your questions into the chat. Would you please take those and put them into the Q&A for me, please? Deborah says, if you, whoops, did we just do that one? If you are JC positive, stop Ocrevus.
I think we
Does,
did that one.
yes,
Yep.
that's what we just did. Okay. So generally, if my legs are still stiff, do I need to up my dosage of tizanidine? And if that is harmful to any organs over the long term, I'd like to know, will I most likely be on the medication forever?
So spasticity in MS, when the legs are involved, it tends to be extensor spasticity. So the legs are going to be stiff and they want to straighten out. So in managing that, certainly tizanidine is one of our more commonly used medications. Typically with tizanidine and baclofen, we're going to go up on the dose until either the person is satisfied with the degree of spasticity and spasm control that they're getting, or they're starting to run into side effects. And most commonly, that side effect with tizanidine and baclofen is going to be drowsiness. The risk of liver injury with tizanidine and baclofen is low. It's not zero. Sometimes, we do blood testing in people with MS, not because of a medication they're on, but because of the medications that they're on. So, maybe tizanidine by itself is not much of an issue for the liver, but maybe the three other medications that are added to it, you're starting to now ask a little bit more of the liver in terms of metabolizing those drugs. So I think getting liver functions, periodically, and if people are on several different symptomatic medicines is not a bad idea. Um, Before we get to drugs like tizanidine, we always want to make sure that the person is in a really good stretching range of motion program. Stretching is your first line of defense against spasticity. Once spasticity has developed in a person with MS, the chances are they're probably always going to deal with some of it. So you're probably always going to have to pursue some type of treatment regimen, whether it's stretching alone, stretching and medications, or then you get up into the other treatment options like Botox, baclofen pumps, medical marijuana. So these are all things that can also be looked at as in the toolbox for managing spasticity.
Thank you. Fred's asking if there's certain standardized clinical assessments that are recommended at a 6-month follow-up with neurologist.
Yes. And so ideally, we would like to, think about objective outcomes in MS. How do we know how the person's doing? And so the things that we probably should get on a regular basis, and you could argue, is it 6 months? Is it a year? I think those are open for discussion, but at least once a year, the person, if they are able to walk, should get a timed 25-foot walk. So that's something that's easy for us to measure. They should get a measure of upper extremity function called a 9-hole peg test. These are just the golf tees that you're going to put into holes and do it with the right hand and then with your left hand and see how long it takes you to get them into the holes and get them back out again. And then a quick cognitive screen called the SDMT, the symbol digit modality test. It's a quick way of measuring processing speed. It is recommended that people get those three things on at least a yearly basis.
Thank you. Desiree said that she's a Connecticut resident and was diagnosed with MS 8 years ago. Her neurologist has never agreed that requesting a complete MRI scan of her brain, neck, and spine was necessary. Her office visits with him have always been an average of 30 minutes and recently began working with a urologist concerning her bladder issues. When she learned that I never had a scan of my neck done, she spoke with my neurologist and advocated for a proper scan so she could determine if MS or bulging discs are causing my bladder issues. Lesions were found, yet with no baseline MRI. I do not know if these are new. I am ready to switch to a different neurologist. Would you please provide your professional opinion about UC UConn and Yale New Haven? I have heard great things about both establishments. What should I consider?
So I think both of those are really fine institutions. I'm probably a little more familiar with Yale. Dr. David Hafler has been the chair of neurology there for quite some time. He's probably one of the world's smartest neuroimmunologists. Lots of great research done. Was at Harvard years ago. So nothing against UConn, but I'm just a little more familiar with the folks at Yale. I think getting in with a good comprehensive MS center like one of those two is probably a good idea. We know that about 75% of people with MS do have demyelination in the cervical or thoracic cord or both. At the time of the initial diagnosis or workup, is probably a good idea to get brain, cervical, and thoracic. How much we do spine MRIs then afterwards is a little open for discussion. When we're doing monitoring MRIs in someone who looks clinically stable, you could argue that we're really looking for asymptomatic lesions, and it's much more likely that you would have an asymptomatic lesion in the brain versus the spinal cord. She raises a good point, though, in people that have different neurological, issues, whether it's weakness or bladder symptoms, making sure that it's not something else, like spinal stenosis, something pushing on the cord, which can give you all of the same symptoms that MS is doing, whether it's, brisk reflexes, spasticity, weakness, overactive bladder. So I would add that the thoracic spinal cord drives us a little crazy with MRI. Technically, it's probably the most difficult for us to look at. Your thoracic cord is a lot skinnier than your cervical cord because the nerve fibers for your arms have come off already. So you're only dealing with the leg nerve fibers. And it's sometimes really difficult to know for sure whether the thoracic cord has changed a whole lot. So I would say it's probably the area that we do the least of, just because of some of the technical difficulties of determining really whether there's anything new there or not.
Thank you. Can you suggest a pain reliever, the best pain reliever for MS, muscular skeletal pain?
So, if the pain is more in the spasticity realm, we're looking typically at things like, tizanidine and baclofen or medical cannabis. Sometimes separating out, what the pain is from is a little challenging. So, people with MS can also deal with neuropathic pain. Classic neuropathic pain is the kind of the burning hypersensitivity, electric shock like feelings, but sometimes people describe just a deep aching sensation that doesn't fit very well with, classic neuropathic pain or spasms. And so sometimes we don't know quite what camp to put it in. And so we just start trying things out. Outside of drugs that we use for spasms like baclofen and tizanidine, a lot of the things we do for pain management fall into one of two camps. Either they're anticonvulsant medicines that have been repurposed for pain management, things like gabapentin and pregabalin or Lyrica, or they're antidepressants that have been repurposed for pain management, things like duloxetine or Cymbalta. And so a lot of times there's trial and error to see, what's going to be the magic bullet for that person for pain management.
Thank you. What's your opinion on taking Ocrevus for someone with 30 years of MS and over 65 years old? Is it
Yeah.
less effective than someone younger with relapsing MS?
Yeah, so again, we touched that thing a little bit on this earlier, that and again we'll do a whole program on this next month. That is a hot topic, and so it does appear that our disease modifying therapies, including drugs like Ocrevus, become maybe less effective as we get older, and the risk also increases, the risk of things like infections. And so there really has to be some discussions with people, and you could pick your age, whether it's 55, 60, about the risk benefits of disease modifying therapies, especially our more effective therapies like Ocrevus as we get older.
Mm. This person says that they are in surgical menopause and their gynecologist wants to increase their estrogen, HRT. Do we know anything about how HRT affects MS progression?
So, there is this research showing that maybe, that MS may progress a little more quickly in postmenopausal women. So that, could that be an argument for HRT? I don't think that there's great science yet looking at, any protective effect of standard HRT in postmenopausal women. There's at the younger end of the spectrum, there's this dramatic effect of pregnancy on an MS, and that hormonal protection appears to be driven by estriol. Estriol is an estrogen that women have most prominently during pregnancy. The rest of the time, most of what we're dealing with is estradiol. If you look at most of the HRTs out there, that's going to be estradiol. The studies looking at estriol's protective effect in women with MS have been interesting. It does look like it seems to offer some protection in relapsing forms of MS in women, but the protective effect seems to go away after about a year. And if you kind of think about it, you will if estriol, if we're treating a woman with estriol, we're kind of trying to mimic that pregnancy, state. Well, women are not pregnant for forever, so they're pregnant for 9 months, and maybe the fact that the estriol protective effect goes away after a year is kind of fitting with what the natural effects of pregnancy would be in a woman with MS.
Thank you. Can tolebrutinib medication for SPMS prevent new lesions, and can it also help with the disability?
So I think the strongest argument for tolebrutinib in secondary progressive MS without activity is slowing or preventing disability. Typically, people with secondary progressive MS without activity are not having relapses or new lesions on MRI. So, whereas I think it's possible that tolebrutinib could prevent new lesions, and there are studies of tolebrutinib in relapsing forms of MS, and it did seem to lower the risk of relapses and new lesions on MRI. I think really our big target for tolebrutinib is going to be disability, slowing and or stopping progression of disability.
Also, are floaters in the eyes common for people with MS, or is it just most likely due to their T1D?
Yeah, so
Um,
so floaters are just common in humans, period, MS or not, and so it really is not an MS thing. So they are, floaters really are you're not imagining that you're seeing them. You're really seeing something. It's usually little pieces of cellular material or protein. They're actually moving in front of your visual field. So yeah, so if you're having a lot of them, certainly mention it to your ophthalmologist as see if there's any concern about things. Where we get nervous is when people started going past floaters and start having like flashes of light off in the periphery, which can be signs of either retinal or vitreous detachment, which are a little more serious and emergent conditions.
I would say most of my friends, and they're all around my age, in the high 60s, almost everybody has floaters.
Yeah, yep,
So,
yep.
yeah. So it's 67. This person's neuro wants them to take Ocrevus for just 1 year. Any thoughts on that?
So there is this concept of kind of induction therapy with highly effective drugs. We used to way back a million years ago when we used mitoxantrone under Avantron, we used that drug for a short period of time to try to, if you will, reset the immune system. And there is some evidence that the B cell therapies like Ocrevus could do some of that. Maybe there is this longer lasting immune effect from drugs like Ocrevus, where so you're knocking the B cells down, and maybe when they come back, they're in a less angry state, and maybe that less angry state does last for a while. So I don't know that we have huge studies saying that doing a 1 year course of Ocrevus is the absolute right thing to do, but it's not a crazy thought either. There is some evidence out there that you may have a long lasting protective effect from doing that, and you're minimizing the long-term risks of Ocrevus, and especially in an individual in their 60s.
Hmm. Ocrevus is a hot topic today. So this
And
person
just
has
I would just throw out there, when we're talking about Ocrevus, just realize that it is a B cell therapy, that we have other B cell therapies, and a lot of what we're saying about Ocrevus is going to apply across the board. So our original B cell therapy off label was Rituxan or rituximab. There are people with MS who are on that drug, even though it's not FDA approved. There's tons of data to say it works perfectly well in MS. You've got Briumvi or ublituximab is the kind of the new guy on the block, and then Kesimpta or ofatumumab is in that same camp.
So this person's been on Ocrevus for 3 years and it's been very successful. So they want to know if there's any clinical studies for an oral medication for primary progressive.
Yeah, so we've tried things, for oral medications for primary progressive. Tolebrutinib and some of the other drugs in the tolebrutinib class are being looked at for primary progressive MS, but nothing that we have that's FDA approved yet. So, as we're talking today, the only FDA approved option we have for primary progressive is still Ocrevus.
Okay, and Sabrina says that she was diagnosed with relapse remitting last December and started Kesimpta. I only have lesions on my brain. I saw my neurologist today and he ordered my yearly MRI and it's only of the brain. Is this normal to only scan brain and not the entire spine?
Yeah, again, this is one of those gray areas where I think, you can make an argument, both ways. Again, I think early on in MS, when we're making the diagnosis, I do think it's smart to get everything, brain, cervical, and thoracic. I think everyone with MS should probably have that at least once. And then what you do going forwards is a little more open for discussion. Again, it's harder to have asymptomatic lesions in your spinal cord. If you form a new lesion in your spinal cord, cervical or thoracic, most of the time you're going to tell us about it. You're going to describe some sort of new symptoms. It's just you think about your spinal cord. It's not very big around. It's hard to put new areas of demyelination there and not have symptoms to go along with it. So, if you had to pick only one area to do in a yearly MRI, you would pick the brain because it's got the biggest volume of white matter. And if you're going to have an asymptomatic lesion, that's probably where you're going to put it. You know, I think if she would like to get the spine done at some point, just mention it to your healthcare team and say, hey, we've never done my spine. Why not? And can we do it?
Thank you. Is there any advantage to stem cells? This is a person who just got on. I think we actually answered that. The son
Yeah, I
was
think we
33
covered that
years
one pretty
old. We
well.
already
So
did that. Yeah.
yeah.
Okay. And Desiree is saying that she neglected to specify that prior to her scan last month, her neurologist has requested brain scans only with and without contrast. So, um,
So early on, when we're just starting following someone with MS, we're probably going to do at least a few scans with contrast. As we follow people over years, there's a lot of argument that we probably don't need to give contrast. Um, with newer MRI technologies, we really are seeing most of what we need to see with MRIs without contrast. There is some evidence that some of the older MRI contrasts may be sticking around in the central nervous system longer than we knew that they did. We don't know of any health risks that go along with that gadolinium staying in the brain, but we don't know that there's not an issue either. And my personal preference is, when we have an established diagnosis of MS and we're just doing monitoring MRIs, I would rather not do contrast.
thank you. This person says, well, they don't want to know if you have any ideas for meds other than Bactrim and cephalexin for recent UTIs. Their Ocrevus infusion has been placed on hold for a year due to these infections, and they're concerned that they'll never have an infusion again due to being diagnosed with PPMS. Any ideas?
Yeah, and so Ocrevus does increase the risk of infections, and UTIs would certainly be up there. Upper respiratory infections would be the other one. If there is really a refractory urinary tract infection, that's sometimes where we bring in an infectious disease doctor. You can't really say that there's a perfect antibiotic because it really depends upon the organism that's growing there. We do see individuals that over years they develop a lot of resistant organisms and they end up with IV antibiotics to treat UTIs, and so it can be a tough situation. This is a great example of where you really have to think about the risk benefit ratio of, is Ocrevus really worth the risk if it's increasing the UTI risk for that individual.
Okay. And Deborah says, I stopped Ocrevus after 2 years because um, after the last one, she had trouble walking. She's 65 and
I think we hit
stable.
that one. I think we got that one already.
We did this one already. I'm sorry. Delete. Um, okay. How about is foot drop permanent? And is the Bioness L300 the best help to get your foot to raise?
So typically when people develop a foot drop or ankle dorsiflexor weakness, it's gonna probably be there for the long haul. I mean, if it came on relatively suddenly, if it's part of a relapse, there's always the potential that it gets better. But most people, if we're having a foot drop discussion, it's probably been there for more than a few weeks, and probably is going to be something they deal with for the long haul. The Bioness unit is wonderful. Our physical therapists love those. The other options that are out there would be the Psionics neural sleeve, which is also an electrical stimulation device. There's the walk aid device that is out there, but of those, I would say our favorite has been the Bioness. You really want to work with a physical therapist who's knowledgeable and can put one of those on you and see if it works out. So I can sit in an exam room as a neurologist, you say, I think you're the perfect candidate for the Bioness device. But then the person gets to the physical therapist and they say, boy, I really don't like how that stimulation feels, or I have a hard time getting the device positioned in just the right place on a daily basis. So I may think it looks great, or the person's going to look great as a candidate, but once they get in with a physical therapist, maybe something just doesn't work out for them. There are other non-electrical devices out there. There's the old-fashioned ankle foot orthotics. There are modified versions called toe-off devices, and then there's an over-the-counter device that we like quite a bit called the Sabo device, Saebo, that for some people fits the bill for foot drop.
Nice. This person's had optic neuritis 5 times much earlier in their life. They want to know if that could have any effect on success rate of cataract surgery, cataract removal.
No, so I mean, if the person has some residual visual loss from their optic neuritis, that's going to cause one set of visual issues, and then if you've got cataracts on top of that, usually that's going to cause some dimming and loss of of kind of night vision capability. But having had prior optic neuritis doesn't affect the success rate of the cataract surgery. It doesn't put you at any higher risk for complications from cataract surgery.
Thank you. Beth started Ocrevus 2 months ago. She said she had her first MRI after beginning treatment in about a month. Oh, she will be having it. If it shows no lesions, do neurologists ever recommend longer than 6 months between infusions? She's 50
Yeah,
years old.
great question. So there is interest in extended interval dosing with Ocrevus. There are studies that have looked at 9-month intervals versus the usual 6 months, and those studies have suggested that the drug remains highly effective at 9 months and may actually be associated with a lower risk of infections. So yeah, it's certainly on the table for discussion.
Thank you. And Maggie said that she was diagnosed with relapse remitting 27 years ago and has been taking glatiramer acetate for 26 of those years. Is there any reason to look into changing her DMT?
So, our goal with every DMT, regardless of whether it's an older one like Latimer or newer ones, is really the same. We want the person to have something called NEDA, no evidence of disease activity, no relapse, no progression of disability, no new MRI lesions. And then the medicine is a lifestyle fit. The person's not having side effects, they've got good insurance coverage, it's not, breaking the bank. It doesn't matter what medicine the person's on. If they're meeting all of those goals, there's nothing to say that that person has to switch to a more effective, a highly effective therapy. Now, when we're starting new people on treatment, it's more likely that we're going to pick one of the newer drugs. But I still have people they're happy with their glatiramer, their beta seron, their Rebif, their Avonex. These are older therapies, but if you're doing well, you're doing well.
Perfect. So this person is planning a trip to Europe and concerned on how they'll feel after jet lag and sleep deprivation. While at home, they generally walk on a daily basis for about 40 to 50 minutes with an average daily step count of 13,000 and do weights 3 times a week. She doesn't know, or he doesn't know, if they are just being overly concerned about making the trip, or is there any advice that you can give on
I
that?
would just go online and look up some of the tips and tricks from, so for transatlantic, transpacific travel, and so look at kind of how you reset your sleep wake cycle. There are all kinds of guidelines on how you kind of readjust to a new time zone. You know, common sense things like staying really well hydrated, trying to just avoid sick people during travel, especially when you're in the airport, strict hand washing, just to keep yourself from getting sick. I don't think I've seen really a higher risk of jet lag in the MS population. Obviously, if you're already dealing with fatigue from your MS, that's gonna be maybe a little bit more of an issue with the travel. But just take a look online at some of the tips and suggestions for resetting your sleep wake cycle when you travel, across the ocean, and when you're coming back as well.
Thank you. This will be our last one because we are at the top of the hour. So we had a holistic, this is from Lisa. She had a holistic homeopathic medicine doctor talk to their MS support group. He was big on pH of the body affecting MS and suggested that they should drink pH drinks. Also, possibly do a 3-day water only fast. Is this sound advice?
I'm not sold on the pH thing, and so I don't necessarily agree with that. I don't think that the pH drinks are going to be harmful, but I don't think it's probably money well spent. There is a fair amount of data out there on intermittent fasting, and so intermittent fasting, along with Mediterranean diet and even the paleo diet, have been shown to maybe be anti-inflammatory. If you measure inflammatory cytokines or chemical messengers, they do seem to go down with intermittent fasting. Um, so I think intermittent fasting, as long as you don't have another medical reason not to do it, if you have diabetes, intermittent fasting may not be a great idea because your blood sugars are going to fluctuate quite a bit. There are people who just flat out don't tolerate intermittent fasting. I'm picking on my wife here. With my wife gets seriously hangry with a missed meal, and she would not be pleasant to be around with intermittent fasting. Other people do great with it and swear by it. I mean, there's good data for weight loss with intermittent fasting. So yeah, I think if as long as you don't have a medical reason not to fast, I think that one's fine. 3 days is a pretty long go round. I don't know that most people could do 3 days fast. I think 24 hours is probably what most people are going to tolerate as a fasting period.
Wow, that's a long time without eating.
Yeah.
So
Yeah.
thank you, everybody. That brings us to the end of our time. I'm so sorry that so many of you didn't get your questions answered, but Dr. Thrower does come back every other month to do this, and Dr. Boster will be here next month to do this on the off month of Dr. Thrower. So that does bring us to the end. So if you've missed any part of this conference, it has been recorded and will be available through the MS Focus Facebook and YouTube channels. Please reply to the registration email that you received for information on how to access the recordings, or just sign up for a newsletter to learn about the upcoming events. Also, you'll be receiving a short survey when you leave the conference. We'd greatly appreciate your feedback, which helps us determine what type of information is most helpful and most meaningful to you. Our next teleconference is going to be this Thursday, just 2 days from now, on July 10th at 6 o'clock p.m. Eastern. Our guest speaker will be MS certified nurse Marie Namey, who will be presenting a wonderful program about MS and bladder health. Our sincere thanks to all of our attendees today for your participation, and especially to Dr. Thrower, who shares his vast knowledge with us every single month and every single year. So enjoy the rest of your day, everyone, and we'll see you next time. Toodaloo.